Let us start our today's session on acute kidney injury, one of the important topics when going ahead with the renal system. And when we often come across patients who are, either a AKI or a CKD or patients of renal disorders, when we encounter them, so it becomes challenging sometimes understanding what exactly is a AKI, when to diagnose AKI, and what are the parameters you will go ahead with the diagnosis, investigations, and management with respect to the management of AKI patients. So we'll be defining what exactly is a AKI. We'll be understanding what exactly is the pathophysiological mechanism of AKI, what and how to diagnose a patient of a AKI, the syndromes which are being associated with acute kidney injury, various strategies, supportive role, and role of renal replacement therapy in the management of acute kidney injury. And then we'll be wrapping our session while discussing a case with respect to the today's discussion. So coming to the overall introduction of this topic, acute, as by the name suggests, it is something acute. It is not a chronic. So something that develops rapidly, aggressively. It is a rapid, but usually reversible. Reversible and rapid are the two keywords you have to look into it. And that means a rapid decline in renal function as evident by rapid decline in GFR, which is being there. So rapid reversible decline in renal function, rapid decline in GFR over a period of hours to days. So it may occur in patients who are having a previously normal renal function, or a patient of already diagnosed kidney disease, a patient of chronic kidney disease who have been recently, so CKD, who have been dealt now with AKI. So the patient can also present, or a newly fresh diagnosis case of a AKI, the patient can be there. So in 2002, Acute Dialysis Quantitative Initiative, that is ADQI, developed a new definition and classification to diagnose this AKI, that is Riffle's criteria, in which they included the risk, injury, failure, loss, and end-stage kidney disease, the various 5 parameters when we're talking in terms of diagnosing a kidney injury of the patient. And in 2007, Acute Kidney Injury Network, that is AKIN, had given a new criteria to diagnose AKI. So acute kidney injury is basically a syndrome. And what exactly it is being characterized by? There is a sudden rapid decline in GFR, that is the glomerular filtration rate, and it occurs over hours to days. There is retention of the nitrogenous waste, disturbance in extracellular fluid volume, because there can be, because of this decreased excretion, there is volume overload, and because of this, there is shifting of the intra-extracellular fluid components, leading to disturbance in the extracellular fluid volume status, along with the disturbance in the electrolytes and acid-base homeostasis, because kidneys are the one of the vital organs for maintaining the electrolytes and the acid-base balance. So, sodium, potassium, bicarbonate. So a lot of things get absorbed, get excreted from the kidney. So if it is a disorder, the disturbance in this can happen. So the loss of kidney function is mostly detected by what? By measuring the serum creatinine levels. So serum creatinine is used to estimate the glomerular filtration rate, although serum creatinine does not accurately reflect the glomerular filtration rate. So recognizing the need of a uniform definition of acute renal failure or acute kidney injury, the ADQI group proposed a consensus graded definition, which was called as the Riffle's criteria. So although serum creatinine is a good marker to estimate glomerular filtration rate, but accurate detection or accurate reflection of this GFR is being not possible, and that's why this Riffle's definition was being given by the ADQI network. So what are the parameters that were there and that is there in the Riffle's criteria? The first is the risk. So serum creatinine greater than 1.5 times the baseline value, or there is greater than 25% reduction in the GFR. And important one more point is urinary output criteria. So we have also discussed in our previous sessions, when, if you remember, when we discussed the respiratory system critical examination and everything, when we discussed even the sepsis and the shock. So the normal urine output should be greater than 0.5 ml per kg per hour. But if it is less than 0.5 ml per kg per hour for continuous 6 hours. That falls into the risk assessment or risk criteria of this Riffles criteria. The second is the injury. Creatinine greater than 2 times the base limit or GFR greater than 50% reduction. Urinary output less than 0.5 for 12 hours. Failure 3 times the baseline serum creatinine. And GFR greater than 75% reduction. But one more important parameter, if this is not being there, then you have just serum creatinine greater than 4. And more falling of the urinary output less than 0.3 in 24 hours, or anuria, complete absence of urine for 12 hours. Loss, so persistent acute renal failure, complete loss of function for greater than 4 weeks, and end-stage renal disease for greater than 3 months. So for Riffles, increase in serum creatinine should be both abrupt, that it should be rapid within 1 to 7 days, and sustained. That means it should be prolonged, that is greater than 24 hours. The AKIN criteria includes the stage 1, 2, and 3. So in stage 1, when we talk about serum creatinine greater than equal to 0.3 mg per dl or greater than 1.5, the upper normal baseline value, but it is less than 2 point the baseline. So greater than 1.5, greater than equal to 1.5, and less than equal to 2 times the baseline. Urinary output again less than 0.5 for 6 hours. For stage 2, creatinine greater than 2 but less than 3, and urine output less than 0.5. And stage 3, creatinine greater than 3 or creatinine greater than equal to 4 with acute rise in greater than equal to 0.5 mg per deciliter, or if the patient is on renal replacement therapy. So this is the stage 3. But if you look into the urine output, it has fallen more, that is less than 0.3 ml per kg per hour for 24 hours. So from 6, 12, and 24, and complete absence of urine for 12 hours. So increase in serum creatinine must occur in less than 48 hours. So this is the Riffles criteria, and the second is the you have the AKIN criteria, which we discussed. AKIN. So Riffles criteria consists of 3 graded levels, which we have discussed. So what are these 3 graded levels when we talk about? So it deals with 3 graded levels which are being there. So risk injury failure, and based on the magnitude of elevation in the serum creatinine or urine output, 2 outcomes are measured, like loss and end-stage renal disease, and Riffles strata are as follows. So if you have to calculate a GFR, it is a very good formula, Cockcroft-Gault formula. And even if, in critical care in emergency, we use this formula to calculate the GFR and to assess whether the patient is developing a AKI or a CKD. So the formula is based on 140 minus age into body weight of the patient divided by 72 into serum creatinine. And if the patient is a female, you multiply it by 0.85. So this is calculation of the GFR in ml per minute. Then you have the modification of diet for renal disease, that is MDRD equation. So GFR is calculated is equal to 1.86 multiplied by creatinine levels into age, and there is a power levels of minus 0.203, and for creatinine it is 1.154. So if the patient is a female, you multiply it by 0.7, but if it is for African Americans, you multiply it by 1.21. But again, if you look at the formula, this is a better formula, Cockcroft-Gault formula, as compared to the MDRD, because this is a more cumbersome to calculate based on the power and everything. So this formula, Cockcroft-Gault formula, is a very good formula used till date to calculate the GFR. Now look at some terms which are being related to the AKI: azotemia, increase in concentration of the urea and nitrogenous substances where in the blood plasma. Uremia is the complex of symptoms due to persistent renal failure that can be relieved by improving the clearance. Oliguria, urine output less than 400 ml in 24 hours. And anuria means complete almost nil, urine output less than 200 ml in 24 hours. So when we look at the data, AKI complicates about 5% of the hospital admissions, 30% admissions to ICUs, a big number. So epidemiology of AKI differs tremendously when we talk in terms of developed and developing countries. Why? Because of the demographics of the country, because of the geographical distribution, because of the comorbid disease economics. For example, if we talk of India, so India is now the diabetic capital of the world. So diabetic nephropathy of these patients, they are more prone to develop diabetic nephropathy. So that's why you have to look into it. So most AKI is reversible, kidney but being the most major organs, its ability to recover from complete loss of its function also. So AKI, but if it is not being treated and if it's progress, it can be a major cause of mortality and morbidity in hospital settings. So in large part due to serious nature of the illness that precipitate the AKI. So when we look at the etiological classification of the AKI, it is classified or divided into three main categories. The first is the pre-renal, then you have the intrinsic, and the third is the post-renal. And intrinsic is further divided into cause of glomerular, interstitial cause, tubular and vascular cause. So these are the basic classification. When we look at the percentage, pre-renal AKI is almost around 55%, intrinsic is 40%, and post-renal is 5% of the total population. Now, when we look at the causes of pre-renal, which is the most common, 55%, it can be either due to intravascular volume depletion or it can be due to effective volume depletion from underfilling of the arterial circulation. So what can be the cause of volume depletion? If there is a hemorrhage, if there is a skin loss from sweat, GIT loss, renal loss, third space loss, if the patient is of burns, traumatized, pancreatitis, peritonitis. So these all can lead to fluid loss, volume depletion. But if arterial underfilling, why? Because of the reduced cardiac output, maybe due to cardiogenic shock, pulmonary embolism, pericardial effusion, or congestive heart failure. Or maybe peripheral vasodilatation because of the anaphylaxis, anesthesia, gram-negative sepsis, antihypertensive medications, cirrhosis, and other liver diseases. And the third is intrarenal hemodynamic changes. So if the patient is on, any renotoxic, maybe drugs that can hamper NSAIDs, COX-2 inhibitors, radiocontrast dye can also lead to, AKI, hypercalcemia, cyclosporin, or glomerular efferent arterial vasodilatation because of these ACE inhibitors or ARBs. So even ACE inhibitors and ARBs can lead to, their effect is, inhibition of the RAS, and because of this, there can be efferent arterial vasodilation leading to kidney damage. Coming to the intrinsic AKI, which we discussed, tubular, vascular, glomerular, and interstitial. So vascular, it can be an involvement due to large vessels or it can be involvement due to small vessels also. Acute tubular necrosis, when we talk about, divided into three main causes. It can be due to renal ischemia, it can be due to intake of nephrotoxic drugs, or it can be due to endogenous toxins. So renal ischemia, why? Due to hemorrhage, due to trauma, due to shock, any surgery complications. Nephrotoxic drugs, a lot of nephrotoxic drugs, antibiotics, aminoglycosides, vancomycin, acyclovir, iodine contrast agents, ethylene glycol, endogenous toxins, myoglobulin, hemoglobin, uric acid. So these are the causes which can lead to acute tubular necrosis. Vascular, large vessels. So renal artery is the prominent artery. So because of any stenosis, thrombosis of this renal artery, diseases of the any glomeruli, glomerulonephritis, any renal macrovascular diseases like thrombotic thrombocytopenic purpura, HUS, DIC, toxemia of pregnancy can also be the cause. Now, acute interstitial nephritis, because of this drug hypersensitivity, because of intake of antibiotics, diuretics, NSAIDs, allopurinol or anticonvulsant drugs, or infection that is associated with acute interstitial nephritis because of any bacterial, viral, tubercular, and fungal infections. Now, coming to the post-renal AKI, so we discussed the pre-renal and renal causes of this AKI. Post-renal, because of any urethral obstruction, bladder neck obstruction, why? Due to benign prostatic hypertrophy, or any urethral obstruction, maybe due to, prostatic cancer, BPH. So these can be the cause of post-renal AKI. Now, when we look at the pre-renal and ischemic pathophysiology, Because of the defective increase in effective circulatory volume, the central baroreceptors get activated and they release angiotensin 2, norepinephrine, AVP or ADH hormone. What this norepinephrine do? It is a potent vasoconstrictor, causes vasoconstriction of non-essential vascular beds to maintain renal blood flow and to maintain GFR. But if there is still hypotension, if there is still decrease in effective circulatory volume, these defensive mechanisms fail, which leads to ischemic injury to the renal parenchyma. So, preferential constriction of the efferent arterioles, there is even synthesis of the prostaglandins, autoregulation, everything try to cope up to maintain the BP. Which further, so this, if ischemic injury to the renal parenchyma happens, because if this hypotension is still present, this fails this renal autoregulatory defense. So what will happen? There will be endothelial dysfunction, medullary congestion, medullary congestion, and tubular epithelial cell damage. And this will lead to, everything will lead to reduction in this GFR. Then recovery of this renal perfusion, regeneration of this tubular epithelium occurs, which can lead to recovery of this GFR. But again, if this persists, there will be more and more damage, more and more congestion, and even this will not get reversed. So when we look at this pathophysiology of ischemic cause of the acute renal failure, decrease O2, what it will do? Increase vasoconstriction. In response to what? Leukotrienes, angiotensin 2, thromboxane A2, decrease in vasodilatation, increase endothelial smooth muscle damage, and increase leukocyte endothelial adhesion, vascular ops. And there is also loss of polarity, apoptosis, necrosis, tubular obstruction, everything leading to inflammatory and vasoactive mediator release, further triggering this cascade and further leading to renal failure. So when we look at the clinical features, so we have discussed the causes of this pre-renal, renal, and post-renal. We have discussed this pathophysiology. Now coming to the clinical features of pre-renal. So because there is fluid loss, excessive fluid loss may be due to vomiting, diarrhea, compromised cardiac function, liver cirrhosis, failure. So what the symptoms can present? Symptoms will be related to hypovolemia only because there is fluid loss. So the patient will get more thirst, decreased urine output. The patient will have postural hypotension. The patient will have dizziness, fatigue, and muscle cramp, which the patient will have. So postural hypotension, dizziness, fatigue, and muscle cramps in the patient will be there. So physical findings, reduction in this ECF volume, what the patient will present. So the cardiac will try to compensate it by tachycardia. There will be orthostatic hypotension, volume loss leading to dry mucous membrane, reduction in the body weight, jugular venous pulse not visible. Arterial underfilling will lead to what? Ascites, peripheral edema, backflow, CHF, and because of this congestive heart failure, there will be pulmonary crackles, pulmonary crepitations, backflow will lead to liver failure, elevated jugular venous pressure, and even ascites. So liver failure will be identified by what? Pulmonary edema, spider angiomas, decrease in the liver size. So when we look at the intrinsic intrarenal AKI, what the patient will present, there will be peripheral edema, raised jugular venous pressure, pulmonary crepitations or rales, or signs of uremia like myoclonus, pericardial rub, or asteractis like flapping tremors. If you tell the patient to extend the hands and extend the fingers, the patient will have signs of tremors. So that is one of the classical signs which you can elicitate. Post-renal failure, again, the patient will present as what? Costovertebral angle tenderness, pelvic and rectal masses, which we have discussed the causes. Why? Because of the BPH, because of the urethral obstruction, and because of this, there will be a distended bladder. So when we look at the differentiation basic between the pre-renal AKI and the acute tubular necrosis, and both of them we have discussed the cause of it. So fractional excretion of this sodium based on this formula, less than 1 in pre-renal. In ATN, it is greater than 1. Urine sodium concentration, less than 10, greater than 20. Urine creatinine by plasma creatinine ratio, greater than 40, less than 20. Urinary urea nitrogen by blood urea nitrogen ratio, greater than 8, less than 3. Urine specific gravity, greater than 1.0, less than 1.0. Urine osmolality, greater than 500, less than 250. Urea nitrogen by creatinine greater than 20, less than 10, and renal failure index less than 1, greater than 1. And when you do a urine sediment, there are hyaline cast in pre-renal AKI, and there is muddy brown granular cast in case of ATN, which is being there. So what you will do when you have identified the patient of a acute kidney injury, so what exactly you will do in the patient? Yes. What are the complete list of investigations you will send in the patient? So all battery of investigations starting from CBC, blood urea, creatinine, serum electrolyte, CPK, very MB, because if there is a tumor lysis syndrome, rhabdomyolysis, this can be a very good marker. If you are suspecting an autoimmune disorder, CNCA, PNCA, anti-GBM antibody is very good. Urine analysis, of course, with urine analysis, urine culture, imaging modalities like CT, USG abdomen, plain X-ray of the abdomen, and MR angiography based on this various cause. So urine sediment in the differential diagnosis of AKI. So if it is a normal or few red blood cells or white blood cells present as a sediment in the urine, it can indicate all this, maybe a differential diagnosis of this. It can be your HUS, thrombotic thrombocytopenic purpura. It can be pre-glomerular vasculitis. If it is a granular cast which is being present, which is muddy brown in color, it can indicate acute tubular necrosis or glomerulonephritis. If it is a red blood cell cast, it can indicate a glomerulonephritis, malignant hypertension, or rarely interstitial nephritis. White blood cell cast may be acute interstitial nephritis, severe pyelonephritis, eosinophiluria, allergic atheromembolic disease, and if there is crystals, maybe due to acyclovir intake, indimavir, calcium oxalate crystals, sulfonamides, and radio contrast agents. So how you will approach to a patient with AKI? So full history, we have been always discussing the importance of history, why history taking is important. So exposure to any of the nephrotoxin or drugs if the patient is being exposed to. And urea may indicate post-renal causes that we talked about, BPH, urethral obstruction. Skin rashes, if it is being there, it can indicate any allergic nephritis disease. Look out for the volume depletion signs if the patient is having diarrhea or any bleeding. Do a pelvic and perrectal examination. And ischemia or trauma to legs or arms may indicate rhabdomyolysis. There is muscle breakdown. There is creatinine loss from the muscle. Prostatic disease, nephrolithiasis. Recent any surgical or radiological procedure, it has been done. Past and present use of medications. Family history of renal diseases, which has been there. So when we look at the physical examination, it should be focused to rule out the differential diagnosis. Very important. Pre-renal cause, we have discussed what will be the clinical signs and symptoms in a pre-renal AKI. All this hypotension, congestive heart failure signs, volume signs. Acute allergic interstitial nephritis is suggested by signs of allergy. And what will be the signs of allergy? Eosinophilia, wheezing, maculopapular rash, or periorbital edema. Lower urinary tract obstruction suggested by what? If there is a flank mass, symptoms of bladder dysfunction, suprapubic mass, if there is hesitancy or urgency of the urine. So what will be the diagnostic workup of a patient of AKI? The first, urine analysis, macroscopic evaluation of this urine sediment. So we have discussed the differential diagnosis of the urine sediments, whether it is a red blood cell cast, whether it is a white cast, whether it is, brownish pigmented cellular cast, and what exactly this cast it can suggest. So pigmented cast without erythrocytes in the sediment from urine, but with positive dipstick for the occult blood can indicate hemoglobin urea and myoglobin. And also along with this, you can do a LDH levels, CPK, MB levels. This can indicate any hemoglobin urea, myoglobin, or if there is a muscle breakdown, rhabdomyolysis is being there. Dipstick test, trace or no proteinuria with pre-renal and post-renal AKI. So mild to moderate proteinuria with ATN and moderate to severe proteinuria with glomerular diseases. RBC and RBC cast in glomerular diseases. Crystals, RBC and WBC in post-renal ARF causes. The second workup, urine and blood chemistry. So most of this test helps to differentiate pre-renal azotemia, osmolality or specific gravity decreased in ATN post-renal AKI, while increased in what? pre-renal AKI. Why this specific gravity or osmolality is decreased? Because in post-renal AKI and ATN, the urine is diluted as compared to the concentrated urine in a pre-renal AKI. 1 by plasma creatinine ratio, normal at 10 or 15:1 in ATN, but 20:1 in pre-renal disease. Why? Because there is passive reabsorption of the urea. There's a high ratio. If it is being there greater than maybe 15, 20, it can suggest pre-renal disease. But this is not a very specific and sensitive criteria. 1 by plasma creatinine ratio. Renal failure index is to ratio of urine sodium to urine plasma creatinine ratio. So urine sodium by urine creatinine is to plasma. Values less than 1 are consistent with what? Pre-renal, whereas greater than 1 will suggest acute tubular necrosis. Fractional excretion of sodium, ratio of urine to plasma sodium ratio to urine to plasma creatinine, expressed as percentage. So urine sodium by plasma sodium divided by urine creatinine to plasma creatinine multiplied by 100. So if this value is less than 1, it is a pre-renal, and greater than 1, it is a ATN. Then comes the role of radiography and imaging. Ultrasonography, again, it will help you to assess the kidney shape, size, whether it is an ectopic kidney, where is the presence of the kidney is being there or not, whether if there is any hydronephrosis, hydroureter. It will also give you evaluation if there is any stones, renal calculi, if there is any renal vein thrombosis, which is being there or not. So complications of AKI, there can be electrolyte disturbance, hyperkalemia, decreased renal excretion, maybe due to tissue necrosis or a hyponatremia, excessive water intake, and there is respiratory failure. So intravascular overload can be there. And the signs there, the patient can present to with pulmonary edema, hypertension, elevated central venous pressure. There can be hyperphosphatemia greater than 5.5 phosphate levels, hypocalcemia, serum calcium less than 8.5, hypercalcemia greater than 10.5. Why? During the recovery phase following rhabdomyolysis, it can be there. And hypocalcemia, decrease in vitamin D absorption, also because of hyperphosphatemia and tissue necrosis, this can happen. So when we look at the various complications, as we talked about, kidneys are a very important organ to maintain acid-base balance. So metabolic acidosis, bleeding tendencies, again, seizures. Why? Due to uremia, more of the failure to excrete urea from the body, may occur due to platelet dysfunction and coagulopathy associated with sepsis. So management of AKI. So we have discussed this, we have discussed the clinical features, we have discussed the pathophysiology, we have discussed the investigations which you will do. Coming to the management. So management definitely starts from prevention, and how you will do the prevention of this patient. So although there are no specific therapies for ischemic or nephrotoxic, many cases of this ischemic can be avoided by close monitoring of this cardiovascular function and monitoring of this intravascular volume status. So what can you take as a preliminary measure? Exclude the reversible causes. Like if the patient is on any renotoxic drug, exclude it. Collect prerenal factors, intravascular volume, cardiac performance, which we discussed in all that list. So the term acute kidney injury now replaces the ARF. So the term ARF should now be restricted to those patients who have AKI and needs RRT, dialysis or renal replacement therapy. So advantage of this criteria, what it was, refers an AKIN, which we discussed, high sensitivity for early diagnosis, allow detection of the patient at risk, and allow detection of the patient with established AKI. So medical management, you have dialysis and you have treatment of complications. Conservative medical management, monitor the fluid intake, do the input-output charting, daily monitor the weight of the patient. So intravascular volume status should be assessed clinically. How much? 3 times a week minimum. And measurement of the electrolytes and sodium, potassium should be done. Measurement of the blood urea levels, serum creatinine, calcium phosphate, central venous pressure monitoring, very much important, should be done. So correction of this underlying disorder for what? For pre-renal. So pre-renal causes we discussed. So there was pure volume depression in pre-renal. So if there is a hemorrhage, you give either a packed RBC. If there is, deficient FEC volume, you have to restore the volume by restoring the fluids. So in severe, blood loss, plasma loss, normal saline, isotonic normal saline is indicated. Gastrointestinal fluid loss, if it is being there, again, electrolyte contained laboratory analysis of the electrolytes is the most precise way for determining the which fluid to choose if it is a GIT loss. So in severe hypovolemia, 0.9 saline can be used, but if it is less severe, 0.4% or 0.45% of the saline should be used. So when you look at there is a volume loss, you have to give a fluid challenge test to the patients. So if the patient is a young stable, give a 500 to 1000 ml of bolus. That should be given within 1 hour. But if it is an elderly patient in which you don't know the cardiac status, you just give 250 ml bolus over 1 hour. Then you monitor the patient for hypo or hypervolemia. Once euvolemia, normal volume is being achieved, monitor the serum electrolytes, and total fluid requirement you calculate based on the total output of the kidney and GI tract in previous 24 hours with additional 500 to 1000 ml inaccessible loss like skin, sweat, respiratory system. If it is ineffective arterial volume with edema, so in case of a cardiac failure, diuretic agents may increase the cardiac output, improve the renal functions, and ACE inhibitors, nitrates, and hydralazine can also improve the cardiac function. Cirrhosis and hepatorenal syndrome in these patients, fluid management may be difficult because assessing the intravascular volume status can be a challenge. So administration of intravascular fluids may require diagnosis and diagnostically and therapeutically. So excess volume may lead to worsening of this syndrome also. So you have to carefully monitor. Albumin may prevent AKI in those treated with antibiotics for spontaneous bacterial peritonitis. But a definitive treatment, if you talk about for the hepatorenal syndrome, it is a liver transplantation, which we discussed in our last session also. But bridging therapies before the hepatorenal syndrome can be terlipressin, octreotide, midodrine, or non-epinephrine can be used in combination with albumin to treat hepatorenal syndrome. Monitoring of the therapy can be done by jugular venous pulsation, central venous pressure monitoring, and based on this orthostatic changes in the blood pressure and the pulse. But if there is a presence of basilar crackles and third out sounds, it indicates that pulmonary congestion is being still present. Central venous catheter is a satisfactory guide to monitor what? To monitor the speed of fluid administration. And what is the normal range of CVP? It is between 8 to 12 cm of water. So in volume depleted states, CVP may be 0 or below. In uncomplicated volume depleted patients, this amount of saline has little effect. So you can give a fluid challenge if there is a volume depleted states, a fluid challenge of 200 to 300 ml normal saline over 10 to 20 minutes. So if there is a CVP rise of more than 5 cm of water, that suggests cardiac failure and infusion should be immediately discontinued because it will worsen the situation. So for acute tubular necrosis, there is no specific treatment. You assess the volume status of the patient. If there is volume deficit, you provide adequate fluid therapy. If it is a euvolumic patient, fluid challenge, diuretic challenge may be tried. And if it is a volume overload, this is given by converting this patient to a oligouric AKI to non-oligouric AKI. Diuretic challenge, IV furosemide 40 to 120 mg over bolus. So if urine output improves, then continue the infusion. Very good, 10 to 20 mg per hour. So diuretic therapy converts oligouric to non-oligouric. May simplify fluid management, but does not improve renal outcomes. Very important. And hyperkalemia complications. So for this, you need to go for, K-binding sachets and everything, calcium gluconate. So routine use of diuretics is not recommended in established AKI. Renal dose dopamine. So dopamine is a renal vasodilator. No evidence suggests that renal dose dopamine is beneficial. Unless dopamine is required for circulatory support that we discussed like vasopressors, it should not be used. Avoid nephrotoxic drugs and adjustment of the drug doses based on the renal clearance should be done. Management of intrarenal and intrinsic AKI. AKI due to acute glomerulonephritis may respond to immunosuppressive agents and plasmapheresis. If it is allergic interstitial nephritis, you can give a glucocorticoids, prednisolone steroid in a dose of 60 mg per day for 3 to 4 weeks. And if it is an AKI due to scleroderma, it can be treated with ACE inhibitors like capto and enalapril. Post-renal AKI, which we discussed the obstruction cause, maybe bladder obstruction, urethral strictures. So urethral obstruction may be treated by percutaneous nephrotomy or tube placement or urethral stent placement. Supportive management, restriction of salt less than 1 to 1.5 gram per day, restriction of water less than 1 liter per day. Furosemide bolus 200 mg followed by IV drip 10 to 40 mg per hour. Diuretic therapy should be stopped, which we discussed if there is no response, and renal replacement therapy and ultrafiltration should be considered. If the patient develops hyperkalemia, restrict potassium, give calcium gluconate, give glucose, GI drip, very much important. So glucose plus insulin is a GI drip. Short-acting beta-2 agonist, salbutamol can be given. K binding sachets, loop diuretics, sodium bicarbonate. And again, if this method doesn't much work, you can go for a dialysis or hemofiltration. If it is a metabolic acidosis, if it is a less than bicarbonate, less than 15, you can go for a sodium bicarbonate, restriction of protein, and consider dialysis and hemofiltration. Hyperphosphatemia, consider restriction of dietary phosphate intake and phosphate binding agents. Hypocalcemia, give calcium carbonate. Hypermagnesemia, discontinue magnesium. And hyponatremia, restriction of oral and intravenous free water. When we talk about the nutrition, this is very important component. So restriction of dietary protein should be there, less than 0.8 gram per kg per day, up to 1.5 gram per kg per day is being recommended. And the best route of nutrition is enteral route. Supportive measures, so sufficient caloric diet, reflect 40 to 60 gram of protein, 35 to 50 kilocalorie per kg of lean body mass, restricting dietary protein, which we discussed in the previous, slide. What are the dialysis indications? We have already discussed. So hemodialysis or peritoneal dialysis, they are equally effective for the management of AR. And what are the absolute indications? Symptoms and signs of uremic syndrome, refractory hypervolemia, severe hyperkalemia, and metabolic acidosis that are not being corrected. So these are the absolute indications for dialysis. So indications: clinical, anuria, complete renal shutdown, uremic encephalopathy, uremic pericarditis, volume overload, pulmonary edema. Biochemical investigations: burn more than 100, metabolic acidosis, hyperkalemia greater than 5.5, greater than 6, and serum creatinine greater than 6.7. So these are the modes. Of course, the modes of dialysis can be either an intermittent dialysis, that is a standard mode which can be chosen. Then you have the intermittent peritoneal dialysis if this hemodialysis is not available, and you have this continuous renal replacement therapy which can be done. Now coming to the indications of renal biopsy which is being there. So what are the indications of renal biopsy when you are having an acute renal failure of unknown etiology? The second is if you are suspecting a glomerulonephritis with systemic disease. So a renal biopsy in such incidences or cases may provide the basis and justification for life-saving therapy. Like if you want to give high-dose steroids, cytotoxic agents, if you want to go for a plasmapheresis. And if acute tubular necrosis is not recovering after 4 to 6 weeks of dialysis with no more recurrent insults. So a renal biopsy at that time may determine a less favorable condition, such as diffuse cortical necrosis that has developed, and that chronic hemodialysis may need to be instituted. So acute kidney injury, we have already discussed pre-renal cause. We have discussed the renal cause, intrinsic ATN, post-renal surgical treatment. Because there is an obstruction, you need to correct it. Pre-renal, of course, hypovolemia, if it is being there, correct it. Euvolemia, give a fluid challenge to the patient. If the patient improve, very good. Patient not improve, think of ATN. If it is an ATN, hypovolemia patient, because ATN due to hypovolemia, give fluids, correct it. If it is a euvolemia, give fluid challenge, improved, very good. If it is a hypervolemia, you need to wash out the excess fluids, give a diuretic. Improved, very good. Not improved, then go for a dialysis of this patient. So the mortality rates among the patients with acute kidney injury approximate almost 50 to 60%. But it should be stressed that patients usually die from sequelae to the primary illness, not from the acute renal failure itself, because of the complications we discussed that happens due to AKI. So mortality is affected by both severity of this disease and the clinical settings in which this ARF occurs. So the mortality of ATN is 60% when it results from surgery or trauma, 30% when it occurs as a complication of medical illness, and 10 to 15% when the pregnancy is being involved. Ischemia associated with acute tubular necrosis that has 2 times the mortality risk of nephrotoxic ATN. And in agreement with this interpretation, mortality rates vary greatly depending upon the cause of acute renal failure. That is almost 15% in obstetric patients, 30% in toxin-related ARF, and 60% following the trauma or major surgery. Oliguria at the time of presentation or rise of serum creatinine greater than 3 mg per deciliter or associated with a poor prognosis reflects the severity of the renal injury and the primary illness. So mortality rates are higher in older elderly patients and in those patients who are having a multiple organ failure. So this we are discussing the prognosis of the AKI patients. So patients with no complicating factors who survive an acute episode of acute renal failure have a 90% chance of complete recovery of kidney function. Very important. So this is the prognosis of this patient. Let us discuss the case which is being linked to this current discussion which we discuss. So patient name Mr. RK. He is a 62-year-old male. He is a retired school teacher by profession. He presents to us with complaints of reduced urine output, that is for 2 days, generalized weakness, fatigue, and swelling of the feet since 1 day. So all three are the important, chief complaints that the patient must look into it. So history of present illness. Patient was apparently well until 4 days ago. What happened? The patient develops acute gastroenteritis with multiple episodes of vomiting and watery diarrhea. So then the patient noticed there is progressive reduction in the urine output. And how much this reduction was there? Less than 300 ml per day. The patient also complained of what? The patient complains of dizziness. The patient complains of fatigue, muscle cramps. Negative history, there was no history of any fever, rash, hematuria, dysuria. So any, acute, any secondary infection, any autoimmune disease, any, muscle breakdown, rhabdomyolysis, dysuria, flank pain was not there. There was even no recent trauma or surgery history. Past history, the patient is on ACE inhibitor since past 10 years. Occasional use of NSAIDs for knee pain. No known chronic kidney disease, no diabetes. Very important. Drug history, enalapride, NSAIDs intermittently, family history, no known history. Pulse is a bit on the higher side, tachycardia, 110 m per minute. BP is 90/60, lower side, orthostatic hypotension. Respiratory rate on the higher side, 20 ml, and the patient is afebrile. Signs of volume depletion, dry oral mucosa, jugular venous pulse not visible, reduced axillary sweating, and poor skin turgor. So if you are pinching the skin, that is taking time to go back to its normal position. So when we did the systemic examination of this patient, the cardiovascular revealed tachycardia, respiratory system was normal, abdominal and genitourinary was also normal. So provisional diagnosis of acute kidney injury due to pre-renal cause due to volume depletion was made. So based on the history and examination, hypovolemia due to GI loss, intrinsic AKI to be ruled out, post-renal cause unlikely. So we ran a couple of battery of investigations and creatinine was on the higher side, 3.2. Urea was also on the higher side, so ratio will be definitely on the higher side, greater than 20:1. Sodium slightly less, 132, potassium slightly high, 5.6, and ABG suggested mild metabolic acidosis. Urine examination, urine sodium was low, fractional excretion of sodium was less than 1, and urine sediments had showed known cast. Ultrasound abdomen, normal kidneys, no hydronephrosis, so a final diagnosis of pre-renal acute kidney injury due to hypovolemia following acute gastroenteritis was being made. So what was the immediate measures? Discontinuing of the ACE inhibitors, NSAIDs was being done. Inserting a urinary catheter. Why? To monitor the input-output chatting. We put the patient on isotonic saline 0.9% NaCl. So we gave 500 ml over 1 hour fluid challenge test, and we monitored the BP, urine output, jugular venous pressure, and lung auscultation. Strict input-output charting, weight monitoring of the patient, monitoring of the serum creatinine electrolytes. Along with this, monitoring of this fluid overload was being done. As the patient developed mild hyperkalemia, we restricted the potassium diet, and metabolic acidosis was being managed conservatively. So after the fluid resuscitation, the PP of the patient improved, urinary output improved, and creatinine started to decrease. So what was the outcome, final outcome? Renal function improved. There was no requirement of this dialysis, and patient was discharged very well with advice of hydration and avoidance of this nephrotoxic drugs like NSAIDs and even ACE inhibitors, which was being there. So there was no requirement of this dialysis, which was being there. So we discussed, let us have a quick overview before we wrap up our today's session. What was the today's discussion of our today's topic of discussion? So just a second. Yes. So we started with acute kidney injury. We discussed the introduction, what exactly is the definition of acute injury, what is the reference criteria, what is the AKIN criteria, how to calculate GFR based on that Cockford's Galt formula. And we discussed some, terms which are being linked to AKI. What is this epidemiology? We discussed the pre-renal, intrinsic, and post-renal classification of AKI, the causes of all these three, and pathophysiology of this AKI. Then going ahead, we discuss the clinical features, we discuss the physical findings of the patients, and what all the investigations we will do to a patient of AKI, and how you will approach to a patient of AKI based on the history, based on the physical examination, and what all the diagnostic workup you will do in a patient of AKI, including the investigations like radiological investigations. We also discussed the complications of AKI. We discussed the management. We discussed the preventive measures. We discussed the medical management. We even discussed the role of diuretics. We even discussed the role of renal replacement therapy. And we discussed the role of complications, if anything, that happen in this AKI. Indications of renal biopsy and what is the prognosis of this patient of a AKI. And then we discussed a case which is being linked to this.